Welcome to the deep dive. We take your sources, articles, research, maybe even your own revision notes, and pull out the absolute key insights. Think of it as your shortcut to getting up to speed fast. And today, we're diving into some specific revision material you've shared on medical topic. Haematuria.
Ah, yes. Blood in the urine.
Exactly. It's pretty common, right? But the causes can be anything from, well, nothing serious to something quite significant.
That's the crux of it, yeah.
So our mission today is to unpack these specific notes for you. We want to make the essential info clear, easy to remember, really high yield so you feel confident with this topic. Okay, let's get started then. What exactly is hematuria according to these notes? And are there different types we need to know about?
Right. So the notes clarify the terms first, which is helpful. What used to be commonly called microscopic hematuria, or maybe dipstick positive hematuria.
The kind you can't actually see.
Precisely. That's now generally termed non-visible hematuria, or NVH.
Okay, NVH. Got it.
And if you can see the blood, the urine looks red or smoky or brown, that's visible hematuria, or VH. That's the macroscopic or gross type.
Makes sense. Visible and non-visible. Clear distinction.
Yeah. And the source mentions NVH, the non-visible kind, is found in about 2.5% of the population.
Wow. Okay, so not insignificant.
Not at all. And logically, the blood is coming from somewhere in the urinary tract, could be the kidney itself, or the tubes draining it, the ureters, the bladder, or the final tube out, the urethra.
Right, anywhere along that path.
And a really key point the notes make right away is about testing. Urine tests for blood should only be done if there's a clinical reason.
Ah, so no random screening.
Exactly. The source is quite explicit, and no recommendation for general population screening for hematuria. You need a reason to test.
Okay, important point. So let's nail down those definitions from the notes again.
Sure. Visible hematuria, VH, you can see the blood. Simple as that. Microscopic. Non-visible hematuria, NVH. Can't see it, but it shows up on a dipstick test or under the microscope, microscopic. Now, the notes break down NVH a bit further based on symptoms. There's symptomatic NVH, SNVH.
What do you means?
That's NVH found in someone who also has urinary symptoms, specifically voiding lower urinary tract symptoms, or LUTS.
Well, you just like needing to go often or urgently.
Exactly. Frequency, urgency, difficulty starting or stopping, that kind of thing. If you have those, and NVH, it's SNVH.
Okay. And the other type?
The other is asymptomatic NVH, ANVH. That's when NVH is just found incidentally, maybe on a routine check or a test for something else, and the person has no LUTS.
Right, just picked up by chance.
Pretty much. And this all leads to a really crucial definition in these notes.
Yeah.
What counts as significant hematuria? This is sort of the threshold for action.
Okay, this sounds important. What meets the bar for significance?
According to the source, it's the NVH. Any single episode of visible hematuria, VH, see it once, it's significant.
Right, makes sense.
Any single episode of symptomatic NVH, SNVH, unless you can clearly pin it on a urinary tract infection, UTI, or some other obvious temporary cause.
Okay, so SNVH usually counts, unless there's a simple explanation, like a UTI.
Correct. And finally, persistent asymptomatic NVH, ANVH. Again, unless explained by a UTI or transient cause.
And how do they define persistent ANVH?
The notes are specific. Persistence means 2 out of 3 consecutive urine dipsticks test positive for NVH.
2 out of 3. Okay, that's a very clear rule. So it's not just any finding of blood, especially non-visible. It's about whether it's visible if there are symptoms or if it's persistently there without symptoms. That's the trigger.
Exactly. It helps focus investigations on those who are more likely to have an underlying issue that needs finding.
Right. So now we know what it is and when it's significant. Let's talk about the why. The notes list a lot of potential causes, don't they?
They really do. It covers a wide spectrum. The broad categories mentioned are things like infections, UTIs are the big one, but others too. Tumors could be benign, could be malignant, anywhere in the tract.
Okay.
Trauma, physical injury, or even just very strenuous exercise sometimes. Inflammation like glomerulonephritis affecting the kidney filters.
Ah, kidney-specific stuff.
Yes. Also, structural issues, things like kidney stones, cysts, funny blood vessels, blood disorders affecting clotting, certain medications, and then another group like contamination from genital bleeding or even, rarely, someone faking it, Munchausen's.
Wow, okay. That is broad. Do the notes highlight the most common culprits?
Yes, thankfully. The common ones listed are UTIs, bladder tumors, urinary tract stones, BPH, that's the enlarged prostate in men, and prostate cancer.
Okay, those seem like the usual suspects for urinary issues generally.
Pretty much. The notes also make a useful distinction for NVH between transient or spurious causes, temporary things or things not really from the urinary tract, versus persistent causes.
Right, like the beetroot example.
Exactly. Transient causes include UTIs, menstruation contaminating the sample, heavy exercise, recent sex, foods like beetroot, certain drugs. Where persistent causes, the ones we worry more about, include cancer, stones, BPH, inflammation like prostatitis or urethritis, and underlying kidney diseases.
That distinction seems really key for deciding next steps. And there was a statistic in the notes you mentioned earlier connecting NVH to malignancy.
Yes, that's right. The source mentions that up to 5% of non-visible hematuria cases might be caused by a urinary tract malignancy, kidney, ureter, or bladder cancer.
5%. That might not sound huge, but like you said, it means 1 in 20 people with unexplained NVH could have cancer.
Precisely. And that's why investigating significant hematuria, especially persistent or symptomatic NVH that isn't easily explained, is so important according to these notes. You're looking for that potentially serious 5%.
Definitely puts it in perspective.
Yeah.
So building on that, what about specific risk factors, particularly for the cancers, kidney or bladder? Do the notes list those?
They do. These are factors that, if present alongside hematuria, would increase suspicion. The main ones are advanced age. Risk increases significantly as people get older.
Okay.
Smoking. This is a major one, especially strongly linked to bladder cancer.
Right. Always smoking.
Chemical exposure. Occupational exposure. Historically, things like dyes, rubber, textiles. Family history of kidney or bladder cancer. And specific medications like anticoagulants. Though the link there is more that they make any underlying bleeding more apparent rather than causing the cancer itself necessarily.
Got it. So for you listening, if hematuria crops up, knowing about these risk factors, especially age and smoking history, really helps gauge the level of concern based on this material.
Absolutely. It's about risk stratification.
Okay. Now, the notes touch on pathophysiology, how the blood gets there. It seems brief, though.
Very brief, yeah. It basically just says blood appears in the urine because there's bleeding somewhere along that urinary tract pathway we mapped out earlier. Kidneys, ureters, bladder, urethra.
So no complex mechanisms detailed.
No, the source just states the specific mechanism depends entirely on the underlying cause. Inflammation might make vessels leaky, a stone scrapes the lining, a tumor grows and bleeds. The how follows the why.
Fair enough. Keep it simple. Let's move on then, because you mentioned sometimes red urine isn't actually blood. The lookalikes.
Right, the differential diagnosis.
Yeah.
What else could cause red or dark urine? The notes first quickly recap the common causes that are usually true. Hematuria, UTIs, stones, tumors, glomerulonephritis, trauma. We've covered those.
Okay.
But then it lists the other causes that can mimic it. This is where testing helps differentiate. These include hemoglobinuria, free hemoglobin in the urine, not whole red cells. The dipstick might be positive for blood, but microscopy shows no red cells, often from red cells breaking down before the kidney.
Ah, okay. So dipstick positive, but microscope negative for cells.
Exactly. Similar idea with myoglobinuria. Muscle protein, myoglobin, in the urine, often after muscle damage. Again, dark urine, maybe a positive dipstick, but no red cells on microscopy.
Gotcha.
Then food. Beetroot is the classic example given. Turns urine pink or red. Drugs. The notes list rifampicin, nitrofurantoin, senna as examples that can discolor urine.
Okay. Common medications, too.
Porphyria, a rare genetic thing where urine can darken, sometimes reddish-brown, on standing. And bilirubinuria, excess bilirubin, making urine very dark like tea or cola, usually points to liver or bile duct issues.
So a fair few possibilities, and you mentioned microscopy being key here.
Definitely. Looking under the microscope to confirm the presence of actual red blood cells is what separates true hematuria from most of these mimics, especially hemoglobinuria and myoglobinuria. You need to see the cells.
Great point. That visual confirmation is crucial. Okay, what about the numbers? Epidemiology, how common is this overall?
The notes state hematuria affects about 2% of people at some point. The incidence, or new cases, goes up with age, and it's generally seen more in males.
Okay, 2%. And for the non-visible type?
For NVH, the prevalence figures vary a lot in studies, apparently from around 2.4% up to over 30% in some groups. But it's most common in men over 60 and, again, in smokers.
There they are again, age and smoking, reinforcing that higher risk group. So when someone does present, what are the typical signs and symptoms besides the blood itself?
Well, the main sign is the blood, visible or not. But associated symptoms give clues. The notes list. Pain during urination, dysuria. Lower abdominal flank pain, that side pain near the kidneys. And those LUTS symptoms, again, urgency or frequency.
Right. So pain or changes in urination patterns, are there specific things mentioned that point strongly towards the kidneys being the source?
Yes, the notes list features suggesting a renal cause. These are important clues. Hypertension, high blood pressure is often linked to kidney issues. Altered renal function tests like a raised creatinine or low eGFR on blood tests. Proteinuria, significant protein in the urine, checked with tests like PCR or ACR. This points to kidney filter damage.
Right, protein leaf.
A history of previous renal problems. Finding a renal mass on imaging. And seeing glomerular red cells in the urine microscopy, those misshapen cells, suggesting they squeeze through damaged kidney filters.
Okay, quite a few indicators there.
Yeah. Though the notes add a useful point.
Yeah.
Just because there's hematuria without significant proteinuria, it doesn't completely rule out a kidney glomerular cause, but seeing both together is certainly more suggestive.
Okay, good nuance. And this all emphasizes why taking a good history, doing a physical exam like feeling the abdomen, checking blood pressure is so critical. As the notes mentioned, you're looking for these associated clues.
Absolutely. History and examination are fundamental. Then you move on to investigations to confirm the cause.
Right. So what's the investigative pathway outlined in the notes?
It usually starts with initial tests. Urinalysis, including both dipstick and that crucial microscopy we talked about to confirm red cells.
Yep.
Urine culture to rule out or confirm a UTI. Imaging typically starting with an ultrasound of the kidneys, ureters, and bladder. Sometimes a CT scan might be used early on too. And cystoscopy using that camera to directly look inside the bladder and urethra.
Okay, those sound like the first line steps. What else?
You also need to check overall kidney health. So kidney function tests from bloods, creatinine, eGFR, assessing for proteinuria, PCR, ACR, and measuring blood pressure. These are all listed as key baseline checks.
Makes sense. Are there more specialized tests mentioned?
Yes. The notes list additional investigations for specific situations if the initial tests raise certain flags. A full blood count, FBC, or clotting screen if anemia or bleeding disorder is suspected. That urine red cell morphology, again, specifically looking for those glomerular shapes if a kidney source is suspected.
Right.
Genetic testing for rare hereditary conditions. Repeat ultrasound if needed. Intravenous urography, IVU, an older X-ray technique, maybe for stones. Renal angiography to look at kidney blood vessels. More detailed CT scanning. And potentially a renal biopsy if things point strongly to a glomerular disease like glomerulonephritis.
Wow, quite a toolkit available. And when do the notes say to call in the specialist?
The key recommendation is to refer patients to urology, especially if they're over 40 or have other concerning symptoms or findings.
So it really sounds like a structured process. Start broad, rule out the common things like infection, get some pictures, maybe take a look inside, and then drill down with more specific tests if needed based on those initial results, like detective work.
Exactly that. Using the clues to guide the next step efficiently, rather than doing every test on everyone.
Which leads us to management. How do the notes say hematuria should be managed?
The core principle is simple and logical. Treatment is dependent on the underlying cause.
Okay, makes sense. Fix the cause, fix the problem.
Pretty much. So if it's UTI, it's antibiotics. If it's stones, it might be lithotripsy to break them up, or surgery. If it's a suspected tumor, that needs urgent further evaluation and specific cancer management pathways.
Got it. Are there specific referral guidelines mentioned in these UK-focused notes?
Yes, they list key UK referral criteria. An urgent referral, like a 2-week wait pathway, for unexplained visible hematuria. Also for VH that persists or comes back even after treating a UPI.
Okay, VH is always urgent if unexplained.
Yes. And then a non-urgent referral for recurrent or persistent unexplained UTIs in people age 60 or over. Even without definite hematuria, those UTIs trigger a referral in that age group, according to this source.
Interesting. So not just about blood in that case.
Correct. The notes also mention when it might be okay to manage in primary care initially. Patients under 40 with NVH, provided they have normal kidney function, no significant proteinuria, and normal blood pressure. Lower risk group.
Right. The younger, healthier group might not need immediate specialist input for NVH.
Exactly. And the notes reiterate the importance of those baseline diagnostic tests, dipstick, renal function, ACR, BP, maybe microscopy, to make these management and referral decisions.
Okay.
And just to hammer it home, the source again states, current evidence does not support routine population screening for hematuria.
Right. So management is all about finding the why through that investigation process and then tailoring the treatment and referral based squarely on that diagnosis. No blanket approach.
Precisely. Targeted action is key.
What about the outlook? Prognosis?
Again, it depends entirely on the cause. the notes say. Prognosis varies based on underlying cause.
So could be excellent, could be serious.
Exactly.
Yeah.
It may resolve spontaneously if it was something minor like exercise-induced hematuria or a treated UPI, or it might require ongoing management or treatment if it's due to a chronic condition like kidney disease or something needing intervention like stones or cancer.
Right. And complications.
Same theme. Depend on the underlying cause. Could be recurrent UTIs, could be progressive kidney damage, urinary obstruction from a stone or tumor, or the spread or worsening of a cancer.
So investigating significant hematuria properly is crucial because ignoring it could mean missing an underlying problem that has potentially serious complications down the line. That really underlines the importance of the whole process described in these notes.
Absolutely. It highlights the stakes involved.
Well, this has been a really thorough deep dive into hematuria, following these revision notes closely. We've covered the definitions VH, NVH, SNVH, ANVH, and that crucial, significant hematuria threshold. We've looked at the huge range of causes, the key risk factors like age and smoking, the clinical clues, the step-by-step investigation pathway, and how management hinges entirely on the diagnosis.
Yeah, the source material lays out a very logical framework for approaching it, from spotting the sign to finding the cause and deciding what to do next.
Definitely. And thinking about it all, especially that point about no routine screening despite the small but real risks of serious causes like cancer,
Yeah.
it does leave you with something to ponder, doesn't it? For you listening. How do you think clinical practice navigates that tension? Balancing the need to find those few serious cases early against potentially over-investigating the many harmless ones. It's a tricky balance.
It really is a constant challenge in medicine.
Indeed. Well, thank you so much for joining us for this deep dive into hematuria. We really hope breaking down this revision material has been useful and high yield for you. And if you are revising this kind of material, perhaps for exams like the MSRA, and want to test yourself further or find more resources, you might want to check out sites like passthemsra.com or freemsra.com. They could be helpful tools on your learning journey. Thanks again for tuning in. We'll catch you on the next deep dive.